Hi, everyone. Logan here with Healthcare Stress Relief and the Healthcare Self-Care Podcast. Today, we have a very special guest, Dr. John Silver. He got his master's in political effectiveness, right?
Pretty much.
Yeah. And he is a registered nurse, and he has been devoting his time trying to understand how we can make this system work. As you know, if you're a nurse or a healthcare professional, it's not working. The burnout rates are higher than ever, and there are tons of issues. And John is one of the few people I've met who's really trying to get the nurse force together to create something new, to pull the rug out of the system that's not working. So welcome, John. Thanks for being on.
Thanks. Yeah, I guess I'm trying to break the wheel, right? So it became pretty obvious to me doing the academic work. And again, I want to reiterate that I was still a staff nurse in an emergency room. It's not like I was in some lofty ivory tower somewhere. And it became overly apparent to me that it's the system design that's causing all these problems. And that until and unless the system gets changed, nursing is still going to be mired in this indentured servitude that we live in. So the question became then, who's going to change the system? So it's not going to be medicine because they make too much money out of this whole deal, especially the specialists. They're never going to go for it. The hospital administrators, of course, aren't going to change anything. The American public, by and large, is woefully ignorant of anything that's going on in healthcare, although they got a crash course over the last year. So, it really falls to us as nurses to do this, to lead this charge, because we have a lot of vested interest in making sure that we have environments we practice in that are conducive to our health, that don't just throw us under a bus, that don't try to live on the edge of chaos all the time, where we're constantly understaffed and ratios are stupid. And so when I started my doctorate work, I was kind of running on two issues. One of them was, well, what kind of system do we need? How do we change healthcare uh, into an effective model that will actually work? And it became readily apparent to me too, as I got into it, particularly in the nursing area, that we need to change nursing too. We're not doing a very good job. The ANA, God bless them, they represent 4 to 5% of the nurses, and yet they're out there being the political voice for the other 95, 96% of us. And nursing leadership has all these affiliations with the American Hospital Association, direct affiliations. So we've got, and I've been writing about this for 20 years, the fractured field of nursing and how we try to pull this together. So I wanted to work on those two fronts. I came up with the model design, which I based on the public utility model, where we change healthcare into a financially sane system that's integrated, state-based regional systems, that's practitioner-led, that can use data to assess where do we put resources? What resources do different communities need? We need to address rural, we need to address urban, we need to address suburban. Right now, we have a big concentration of resources in suburban areas in some parts of the cities where people are insured and they can make money. We have to start thinking of this, as we should as nurses, that we have an obligation, not just to our patients, but to our communities and our states and our country to improve health. That's kind of our mission. And nurses are the experts in how do you deliver healthcare. There's a lot of other experts in, how you do PT and how you do speech pathology and diagnosing disease, although we're creeping there too. But the actual delivery process of healthcare to people is uniquely nursing. And we've got a history that goes back to the 1900s in being able to do this and do it effectively. So I want to restore that part of it. So I came up with a mission and vision for nursing. I then worked on this public utility design. But after studying, just about every other system on the planet, and once I'd established the goals of what a healthcare system should be, it was easy just to go down the list and say, well, you don't make it, you don't make it, you don't cut it, you don't cut it, you don't cut it. And of course, our system didn't, satisfy any of the goals. And certainly from us as practitioner level, it wasn't satisfying any of the goals. Physician suicides are up, nurse suicides are up, nurses are leaving the profession. This is now the fourth wave in some areas of this COVID epidemic. People in the communities aren't listening to us, and it's because we're not in the communities to start with. They don't have a voice that they trust. And if we were community-based and we were actually out there, I think we could have done a ton of stuff, even from the very beginning of 2020, in terms of advising people and giving them credible, science-based things that we need to do. So this public utility model is I think, the answer. I've taken every one of these goals down to the street level. We have models all around the country and the world that show this type of system delivery works. But we need to generate the political will to do it. We're never going to compete with the $100 million that the top 5 lobbyists gave in 2019 to the political system. That's never going to happen. But if we could get just 10% of the nurses together, we would be the largest nursing organization in the world. We would be able to go public into national media and lay out this option, which has been completely, well, I don't even know if they think about it, completely off the table. And I think when the American public hears of this, that, for example, you don't need insurance anymore, that these systems are service-based, no more co-pays, no more deductibles. Companies don't have to, hire people to manage health insurance plans. They don't have to worry about providing health care to their employees. All of us pay into this system, but at an incredibly reduced price than what we're paying right now. There's no more 18-year-olds all of a sudden looking at $2,000 a month because they're type 1 diabetics. I would have the California ratios implemented nationally for nursing. We'll restore nursing under nursing. We'll have accountable administrators with senior chairs elected by nurses, not appointed by some, business body. So I think there's just so many advantages for all of us in this system. The question is then, who's going to lead that charge? And I think it has to be nurses. We have the numbers power. It's a matter of getting us together and then working with partners to present this option to the American public and explain why the benefits are worth changing this institution, which, let's remind ourselves, is only about 60 years old. It's not like healthcare was embedded in the Constitution. Back then they were giving you cathartics and emetics and bleeding you. So this notion of a healthcare system is new. It's evolved sporadically, chaotically. It got taken over by big business and corporations starting in the 80s en masse. And what we've seen is they're just taking over everything. They're taking over medical practice. They're taking over, completely dominate nursing. So let's get together and change this. We can do it.
Yeah, I'd love to dive more into the public utility model. So you went to several different countries, South America, all over Europe, and you studied and talked to people working within the healthcare systems. So this is not socialism and it's not free market.
Correct.
And can you explain, I know there's 7 main things that you came up with, but can you explain, because I believe when we talked earlier, you said that none of the countries are implementing all 7 of these things.
Right. So the first big task I had, I thought as a philosopher, was trying to define the goals. How do you set up what are the goals of a healthcare system supposed to be? And I ended up having 7 goals. Was lucky enough to be able to travel to Argentina for a couple of weeks. And then I gave a talk in Berlin, actually to a design conference, which was interesting. And then I went back to the first STTI Nursing Honor Society meeting in Europe, met nurses from all over Europe. We talked about healthcare for days. I came back, I took all the models I could find, Canadian, Australian, New Zealand, Asian, South American, European, anything I could find, I put it on the table. And I just did a process of elimination to see which one of those models met all 7 of these goals. And none of them did. And of course, our system doesn't meet any of the goals. So I thought, I got to reframe how I think of healthcare. So once I started thinking of healthcare as a service that's provided to communities, not individual interactions, it kind of cleared up the picture a little bit. It kind of changed the focus. So then I went back and asked American history, when have we had, because we have to have had this problem where something was too important to be a commodity, but we weren't ready to cross the line and call it a right. And that definitely happened with electricity in the 1920s. And FDR's solution to that was the public utility model, which was borrowed from the natural monopoly theory, which had come out of England. So when I put that model on the table, it worked if I changed 2 of the variables. The one we sort of talked about, which was the financing of it. So everybody has to have a hand in this pot. We all have to pay. We know that healthcare is a national security issue. We saw that after 9/11 when the 65% of the people that applied patriotically to defend the country in the military were rejected because they were physically unable to be able to join the military. We have massive obesity rates. We have massive type 2 diabetes. Everybody knows the statistics and the problems. So I had to think, if we need to change that financing system so that we have predictability, and that we're making sure that the services are covered and we're not worried so much about making profit out of everything. The other thing that had to be changed was the leadership structure. So the administration of my system is practitioner-led. I have a nurse as the chair for philosophical reasons. And that is that it doesn't make sense to me to put people in charge who have a vested financial interest in making sure they're the most successful party. I don't know if that makes sense.
Totally.
In nursing, in theory, us as nurses, our entire focus is on the other. It's not on ourself. It was on ourself, we'd have revolted and taken over our own practice domains 3 decades ago. But we didn't. So we've been pretty consistent historically that we're really interested in helping other people. So one of the first things I did was I wrote a Declaration of Independence for nursing. And I based it on the American Declaration of Independence. Thank you, Mr. Jefferson. And because, well, their issue was representation without, or taxation without representation. Our issue is we don't have any representation. And that's what we really need. We need to be at that power table. We need to be talking to politicians. We need to be doing these things. Again, not so much for us, but for our patients. And I think restoring the mission of nursing and restoring the mission of medicine and these other professions that work with us, I think you're going to, and I know because I've already talked to a bunch of them, of all kinds of specialties. They want to get back to being able to provide their services to people. They don't want to have to deal with 1,500 different insurance programs or worrying about pre-authorizations or all of us are capable of peer reviewing our own professions. And that's what we need to get back to. So anyway, that's where I sort of ended up. To be honest, I'd kind of given up because, philosophers have been kind of dead. Postmodernism came out and there was no truth anymore. And then we saw in politics it filtered into that and there's no truths anymore. And But when the COVID epidemic hit in 2020, I started getting PO'd. And I had the opportunity to go on some podcasts. I was absolutely blessed to be tied together with the people I work with now, Kathleen Bartholomew, who wrote The Dauntless Nurse, Melissa Cortez, who runs Cortex Energy Systems, trying to help nurses with this pandemic stress. Kim Evans, a integrative health practitioner, is a nurse practitioner out of Kentucky, who also wrote a book, Transforming Healthcare. Leanne Myers, the podcast host. Recently, we've also included Beth Haney, who's a councilwoman in California, also a nurse practitioner. So we're starting now to take this message out publicly. The problem is, how do you connect with nurses? We're a really disparate group. There's no single communication. I can't write an article in the American Journal of Nursing and have it reach nurses because only 4% of the nurses belong to that. So how do we communicate with each other? Melissa is brilliant in this, and I know there's nurses on TikTok, and I know there's nurses on, well, I have to be honest, I'm old. I don't know all the platforms. I apologize. But is LinkedIn where you're going to meet staff nurses? I'm not really on Facebook because it just got absolutely too stupid at the beginning of 2020, and I was done with it.
It's still stupid now. Yeah, don't go back.
Yeah. So the question I'm trying to do, or the thing I'm trying to do, is reach people who are reaching staff, particularly staff level nurses, to say, listen, let's take this negativity, and there's tons of it out there, and let's do something with it, not just because I'm telling you the truth. The minute this crisis is over, they're just going to go right back to the same thing they've been doing all along.
Yeah, I think if anything, the crisis has only opened up the eyes of the staff nursing to how bad it is. But we all already knew this. It's just now it's become even more painful. So what are we going to do about it?
Exactly. Well, it threatens our own lives now. I mean, 31 years ago, I didn't sign up to be, in perpetual germ warfare.
Yep.
We had our issues. I went through the AIDS epidemic, so I'm well aware of, contagious diseases. In this case, HIV, we didn't even know what it was for years. The Hep C scare with blood supplies, the outbreaks of this and that. But this is different. And this is killing healthcare providers. And the gross driver of that is the ignorance and misinformation that's being put out there. And I think a lot of the public doesn't know who to trust. Yeah, and that's why a community-based healthcare system would be hopefully more trustable than, a CDC announcement or infectious disease doctor. I want to say one other thing about the US. The other thing you have to respect in the US, there are two things. One, you can't fall into that socialist trap. You brought that up earlier. The second thing is you have to respect state and federal boundaries. There is a federal society here. So my system is set up in state-based regions, and that's why it's set up that way.
So basically, if this were to work effectively, when it does work effectively, you're just going to spread it through states, just like California formed strong unions and got better ratios.
Well, the California history, actually, I wrote a book about it. So I wrote the history of the California nurses. What I was trying to do was show nursing that there is a model out there for becoming politically effective. And that's the message I was trying to get through the book. It's not so much that I was writing about a union. I was writing about a group of basically bedside nurses that actually managed to get policies passed at a state level. They're the only group that's been able to do it. And I write about that process. What a lot of people don't understand is that when Gray Davis signed that law in 1999, there were no ratios in that law. It was referred to the California Department of Health. They spent years taking testimony not just from California nurses, but from the hospital associations, from nursing leadership groups. And they're the ones that established the ratios. And it's not that I think this needs to be imposed, with nails in it down to the board. So it's rigid and all that stuff. What I want to do is set that as the baseline in this model. And then the ultimate goal would be to have actually empowered clinical leaders on the floors that could make real-time decisions based on what the needs of their units are, not on some matrix that the CFOs decided has to be adhered to. But that's going to take a couple of years because nurses need to learn that they can be assertive like that.
I have tons of questions for you. Number one, administration and the Doctors Association, and then we have the Nurses Association. Those are the three main entities. The Nurses Association is pretty much the weakest link because I would say industry leverages our compassion against us. Would you agree with that? And
politically, yeah.
Yeah. So you mentioned earlier that the big businesses are going to fight tooth and nail with this. So how do we essentially get this politically passed and start talking about it more? Obviously, uniting 10% of the workforce, what would that be? 300,000 nurses?
Yeah, almost 400,000.
Okay.
You can initiate it with a lot less, but that would be the number that would get you seated at the International Council of Nurses. That would be the number that when you walked into a congressman or senator's office, they're going to be polite.
Okay, so what we need is 400,000 nurses, not in the beginning, but that number over time.
That'd be good
to basically be on this page, right?
Yeah.
To understand this model and to speak up for it.
Yeah. So politically, it's actually the legislation itself isn't that hard. It's getting them to do the legislation. So politicians respond to two pressures. The first one is money, because they're in a constant need for continuous funding. But the other thing they respond to are voters. And if you can mobilize through our messaging, if we can mobilize enough public support, the last thing they want to do is lose their jobs. Politics is a cakewalk.
Really?
I mean, they make pretty good bucks. Look at how many of them make a heck of a lot more money than that while they're in office. And it's pretty cushy work. So none of them want to give this job up. And if you can start taking these arguments down to a voting district level and start putting pressure on these people, I think they will do what they need to do to stay in office.
So we essentially have to unite the people, and we can do that by visiting your website, right?
Well, the NTH website is kind of like an umbrella. It's what we would like to do is just have people join, and hopefully groups start joining. We're in touch right now with the Nurse Practitioner Association, the Integrative Practitioner Association. So it's kind of an umbrella group. So if you have an advocacy, because there are over 800 nursing groups, if you have your small advocacy group or something, you can join under our umbrella. That gives us credence when we go out and talk publicly. Donate or don't donate. And obviously donations would help us because it's just the five of us trying to finance all this. And then we can get, like upgrade our website. We can start having discussion boards. We can add all these bells and whistles under our site. We'll load the Declaration of Independence. You can, donate and sign your name to the declaration if you want. So it just takes development. And that's what we're kind of at now, is trying to piece together some development money so we can get some things going.
And that's at nursestransforminghealthcare.org, right?
Correct. One word, Nurses Transforming Healthcare, all lowercase.org.
Great. Are we still good for time right now, John?
Yeah.
Awesome.
Yeah, I got to get going pretty soon though. Sorry.
Okay, no worries. Really quick, I just wanted to go through the goals of of your model. I have it all written down. One is equitable access.
Well, appropriate to the community's needs.
Mhm.
So, you can have a rich kind of affluent community and they may need some access to primary care and a facility somewhere, reasonably close. Whereas you go into some areas and they may need 24-hour clinics. So it's based on the data of that community and what they need. Yeah. But it should be fair to everybody.
And then two is equitable, targeted, and evidence-based distribution of resources.
Exactly. Right now, and that's people too. Right now, we have an extreme concentration of resources in areas with high insurance populations.
So cities.
Well, some areas of the cities, because remember, cities have different areas. So you may have, like one overwhelmed hospital in a poor area, and then, no wait, three other hospitals are sitting in these kind of richer areas.
Three is interdisciplinary practitioner-led administration. So that goes back to allowing like NPs and the nurses to really become the administration instead of having somebody over them, right?
Right. And there's two big goals of that. One is that the entire system then becomes congruent with their values, right? So that the entire system understands what it is we're trying to do. And also you need to be able to maximize their skill sets. So part of that is nurse practitioners, PAs. We want everybody to practice at the scope of their practice, but then also be under the peer review of their own professions.
Four is equitable and positive outcomes. What does that mean exactly?
Well, if you go into healthcare right now, I think healthcare now is considered like the third or fourth leading cause of death.
Yeah, so that makes
we got to
sense.
change that.
Yeah.
And the way we change that is we make it sane nursing care, sane medical care, specialists, like hospital-based physicians taking care of patients in hospitals, using things like intensivists in our critical care units, and then making sure we have the preventative and the primary care services out there available so that everybody's getting equitable, fair, and yet your experience with healthcare is a positive one. You're coming out with either information or treatment that you need.
Six is cost effectiveness. Pretty explanatory.
Yeah, you can't be, 50% of bankruptcies can't be because of healthcare. That's absurd. You can't have people, especially elderly, sitting there deciding whether they take their pill or they eat. That's just pathetic. And that has to end.
And then finally, social accountability. So more people and communities holding the citizens accountable for their own health, right? Instead of just disease care.
Well, and also that the community is holding us accountable, that we are meeting their needs in terms of resources. And then I also put in direct public reporting as an essential requirement. So either on a biannual basis, that regional council needs to come on and do a public address and explain, what our problems are in these communities. Is this, gun violence in one community? Is it STDs? Is it mental health? What are we looking at, and how do we sum up the health of our region so that together, community and healthcare system can start addressing, what we need to do to solve these problems.
Great. I have one.
It's not just us, it's public health too. So for example, the nurse that's making the home visit in one place in an apartment may see rats and peeling paint, and they can go right back and file a report with public health, who can then go down there and start holding these landlords accountable. Maybe it's a waste dump that was never really excavated appropriately, or, billowing smoke and chemicals coming out next to a neighborhood. We have to start looking at these determinants of our public health and taking them on too. Food industry is another example.
Yeah. My final question: of all the models you've studied, what country do you feel has it together the most?
Well, in some ways it's kind of unfair. So Well, I mean, if you look at a country like New Zealand, you can say, wow, New Zealand has kind of their act together. But when you realize they've got a population half the size of New York State, and they have a very small geographic area, really, that's, living in, where people are living in, that makes your problems a lot easier than if you have 331 million people spread out over 50 different states in all kinds of regions everywhere. So it's not really fair, I don't think, to compare the model of Germany versus the model of the US. We have to start thinking of the model that best meets our needs.
Yeah.
And again, for all of us, not just, people making money.
Great. Thank you so much for coming on, John. I appreciate all the wisdom. And to anyone who wants to join the force, go ahead and visit the website. And how can people best reach you, John?
I'm pretty easy. You can reach me through NTH, or you can send me an email. I'm pretty approachable. So it's Forrester, all lowercase, FORRESTER 2232 @gmail.com. I'm more than happy to come in and Zoom with any group to explain this, to have a discussion, to however big Zoom can get. I'm willing to do it.
Amazing. Thank you so much, John.
Oh, Logan, it was an extreme pleasure. And I hope anybody listening can feel the urgency that we need to get going on this.
Absolutely. Take care.
Thanks. Have a great day.
Bye.